not every baby can successfully be treated with non-invasive support. So we do have to ventilate. And when we do, I will try to convince you, if you don't already do that you should probably use volume targeted ventilation. And I think many of you do. I know they do here on Curacao. But it turns out it's not as simple as some people think. And one size does not fit all is the bottom line. So we're all trying very hard to avoid chronic lung disease, acute lung injury, depicted here. We all understand how it, more or less how it works, right? You have this influx of activated neutrophils releasing a variety of markers and mediators of inflammation. And then the whole process of injury and repair is triggered. It can be triggered in utero already with chorioamnionitis. So we're all trying hard to avoid going that route. It's important to keep in mind that BPD is the pathophysiology of it, or pathogenesis rather, is very multifactorial. There's not going to be one simple solution that's going to fix all the problems, right? Because we have so many things that impact it. I already mentioned choreo can trigger process right away already in utero. There is all this stuff that goes on in the delivery room, which is a whole conference of its own. And we don't have time to go over that, but initiation of air breathing is really important. Mechanical ventilation plays an important role, but certainly not alone, right? Exposure to oxygen means babies who lack antioxidants, infection, lots of things. Then there's a few things we can do to mitigate things. But the important thing is that these babies are being born at very early stages of their lung development, and injury is easy to occur at this point. And so we need to have a package deal. One simple intervention is not going to correct all the problems, but we can avoid adding old BPD on top of the probably inevitable new BPD in our extremely preterm infants, in whom the arrest of normal alveolar development is probably inevitable, but we can try to minimize additional injury on top of that. And so I'll try to show you some data about volutrauma rather than paratrauma. I think you all know that it's really easy to inadvertently overventilate babies with pressure controlled ventilation, and you know that it's bad for the brain and the lungs. And I'll try to draw your attention to the distinction between adult type volume controlled ventilation and what we actually do in the NICU. So this is not news. This has been around for a long time. It's still amazing to me how dramatic the differences were. So these were some studies in rodents where in the white bars were animals whose chest wall was free to move and the lungs were free to expand. In the black bars are animals with a plaster cast applied to the chest and abdomen to restrict chest wall movement and therefore tidal volume. And they were exposed to progressively higher inflating pressure. And they looked at capillary filtration coefficient, basically a measure of acute lung edema, acute lung injury. And so at 15 centimeters of pressure, nothing was happening, no difference. At 30 centimeters, these animals with healthy lungs already experienced significant acute lung injury after only 15 or 20 minutes of ventilation. It's not surprising that with a very high pressure of 45 centimeters, there was a great increase in capillary filtration. But what is surprising that animals exposed to the same inflation pressure, but where the tidal volume was constrained, did not experience that lung injury. So it appears from that and many other studies that the harmful effect of positive pressure is really mediated through overexpansion of tissue, excessive tidal volume. Stretching of tissue, we know, causes disruption of the airway and alveolar epithelium and leads to lung injury. There's a similar experiment where they added a third dimension. So they were similar two groups. This was also a rodent study. They looked at three different indices of acute lung injury. Again, basically water and albumin space, so protein leak as measures of acute lung injury. So the same group in terms of high pressure with free to move. The green were high pressure, but strapped, the chest was strapped with tight elastic bandage. The yellow bars are animals in whom excessively large tidal volumes were generated with negative extrathoracic pressure. So remove the positive pressure. So you can clearly see that whether the large tidal volume was generated with negative extrathoracic pressure or positive pressure, there was a great deal more lung injury than the animals exposed to the same high positive pressure, but constrained lung movement or tidal volume. So we need to keep in mind how the lungs and lung mechanics respond when we use different primary control variables. So pressure, control ventilation. Pressure is the independent variable, right? So, and if at whatever pressure we have set here, this is the tidal volume we get. So this is your standard pressure volume loop. Pressure, volume on the vertical axis. If compliance increases, what happens? Well, the pressure is fixed. So what happens is that the tidal volume goes up. That may be a good thing if the tidal volume was inadequate initially, but if the pressure was adjusted to deliver an appropriate tidal volume and all of a sudden lung compliance improves, you potentially overexpand the lungs and generate an excessively large tidal volume. In contrast, when volume is the independent variable, volume is fixed. Oops, I keep those buttons are next to each other. At the volume is set, and the ventilator generates whatever pressure is needed to deliver that tidal volume. Now, if we improve compliance, what will happen is the following. Of course, it just takes less pressure to deliver that same tidal volume. So this is the lower pressure, but volume remains stable. And of course, tidal volume is what determines your minute ventilation, CO2 removal. Also, volume, of course, we talked about volume trauma already. So the adult kind of volume controlled ventilation. So there's two ways of delivering or regulating tidal volume. One is what PICU and adult ICUs do, and what some of our ventilators like the servo has a volume controlled mode. And in these volume controlled modes, you have a ventilator that generates the tidal volume, measures it, regulates it here at the ventilator end of the circuit, okay? And a significant portion of that tidal volume dissipates to compression of gas in the circuit, which can be compensated. And there's this compliance compensation feature that works pretty well, unless there is a leak around the endotracheal tube. And when there's a leak here, that compliance compensation begins to break down, and there is no compensation for the leak around the endotracheal tube. So this becomes problematic. We tried, of course, in those days, there were more primitive devices, but in the 1980s, we tried volume control ventilation in neonates, didn't work very well for these reasons. So we all defaulted to pressure control ventilation, which in its basic functionality is nothing more than a mechanical T-piece resuscitator. And during the expiratory phase, you have continuous flow of gas in the circuit. There's a PEEP valve maintaining some distending pressure. Baby can breathe in and out of the circuit during the expiratory phase when you're in SIV mode. And then when the ventilator cycles on, the expiratory valve closes, the circuit's pressurized, and gas flow is diverted into the patient's lungs. And the volume that enters the lungs is a function of the positive pressure within the circuit and the compliance of the lungs. That's the basic functionality of pressure controlled ventilation. And the problem of leak around the endotracheal tube doesn't really exist because there's plenty of fresh gas flow available. Excess gas overflows over the pressure limiting valve. So we don't care there's a large leak. And it was the ease with which you could ventilate babies with large endotracheal tube leaks, and the conviction that pressure is the bad guy, pressure is the cause of all ills, and we like to control it, that led us all to use pressure controlled ventilation. But of course, there's a problem with pressure controlled ventilation, as I showed you before. And that has to do with changes in lung compliance. And when lung compliance changes, whatever pressure we had before can generate much larger tidal volume. This has to do with the fact that this is the sort of stylized pressure volume compliance curve. We know that compliance is poor when the lungs are largely allostatic. So here at the flat lower portion of the pressure volume relationship, the FRC is low, and there's diffuse microalectasis, and the compliance is low. We do everything in our power to get the baby's lungs expanded. We use adequate PEEP, we give them surfactant, they start to clear their lung fluid, and they move onto this nice steep portion of the compliance curve where relatively small pressure change leads to large change in tidal volume. That's great, except when that tidal volume becomes excessive, and now we're potentially in trouble. So, well, there were problems I explained to you about volume control ventilation. So what we do today is something I like to call volume targeted ventilation. It's not volume control, it's volume targeted. And volume targeted ventilation really is pressure controlled ventilation with automatic adjustment of inflation pressure, or PIP, okay? So the flow waveform is the same as pressure controlled ventilation. We have, pressure circuits pressurized, flow goes in, generates a tidal volume, and that's all good. That's how that works. And with volume targeted ventilation, that pressure is adjusted automatically to maintain that stable tidal volume. With volume controlled ventilation, there is a fixed volume that the ventilator will deliver. It does so by generating a constant or slightly decelerating flow, and that flow continues until the volume is delivered, and then the ventilator cycles off and pressure rises passively and reaches peak just before exhalation. It's a derived variable. There is no direct control over that. And so the lungs fill fully only at the very end of the cycle. And so it's a different flow pattern. And so this is how pretty much all of the volume targeted modes work now. Certainly PRVC and volume guarantee work by these algorithms, where there's an initial pressure generated. Tidal volume is, the resulting tidal volume is measured, and it's compared to the target. And if that measured tidal volume is below target, the inflation pressure goes up. If it's close to target, no change. And if it's above the target, the inflation pressure will come down. And so there is always a little delay in getting the tidal volume exactly where it's targeted. And part of that problem is, whoops, sometimes my graphics get messed up when it changes ventilators. So we're going to have to ignore that. But basically, this is showing that if the tidal volume, which is shown here, but you can't see, is below target, pressure will go up. If it's on target, no change. And if it's above target, the pressure will come down, but the slide somehow got messed up. All right, so I'm going to draw the contrast between NAVA, which I briefly talked about in the previous talk, and volume targeted ventilation. So if you measure the electrical activity of the diaphragm with this NAVA catheter, you can do that with NAVA. And in Europe, they have something called proportional assist ventilation, which is a very similar concept. And they're both positive feedback. So when there is little effort generated by the baby, there's not much pressure delivered by the ventilator, because it is assumed that the baby knows what they're doing. And when the baby breathes more vigorously, more pressure is generated. In contrast, with volume targeted ventilation, if the baby hypoventilates or is apneic, the ventilator generates more pressure to try to maintain a stable tidal volume. And when the baby is generating very strong inspiratory effort, the pressure comes down to avoid excessively large tidal volume. The problem with NAVA is that babies with immature respiratory control tend to breathe like this. And if you superimpose positive feedback on this, you're probably going to run into all kinds of trouble. So I know some of you have here on the island, they have the servo machines. I don't know if if you all have the NAVA module, but this is the problem with NAVA. The promoters of NAVA are very proud of the fact that the pressure generated by the machine very closely tracks the pressure, the effort of the baby. So baby hypoventilates, not much support. Baby breathes more normally. Okay, we're good here for a while. Hypoventilates again, not getting any help. Then there's a vigorous inspiratory effort generating a pressure close to 40 centimeters. So up and down. So it's accentuating the immature respiratory control, the highly variable respiratory effort on the part of the baby. And I think that's a dangerous thing. So back to volume targeted ventilation, which I think is the better approach. We know it is able to maintain a relatively stable tidal volume, relatively constant, but it does fluctuate a little bit because baby spontaneous effort does fluctuate, and totally monotonous tidal volume is not a good thing. It leads to atelectasis. So some variability is healthy, but most importantly, prevents overdistension, prevents volutrauma, and overventilation when lung compliance changes. So when we give surfactant, we recruit lung volume, babies clear lung fluid, the ventilator adjusts in real time. Okay, the algorithm works 7/24. It doesn't wait for the next blood gas. It doesn't wait for morning rounds. It does what it's assumed, it's what it's supposed to do, and leads to more rapid weaning from mechanical ventilation. And it compensates for the highly variable respiratory drive of the preterm baby that I showed you, that periodic breathing. So it stabilizes minute ventilation. And so there have been a few meta-analyses. There is not a single large randomized trial that has been done. We had one approved in the Neil Research Network, but it was never prioritized for funding. So we rely on this meta-analysis. There has not really been anything new published since then. But it includes over 16 studies, almost 1,000 babies. The combined outcome, the point estimate suggested a benefit, but the confidence intervals cross 1, so not significant. But everything else is significant, and so there is more than 25% reduction in BPD at 36 weeks. This is the range. And the number needed to treat is only 8, which is remarkably low. Severe interventricular hemorrhage, or the combination of PVL and severe IVH, both about 50% reduction. Again, these are the confidence intervals, so highly significant. Number needed to treat, only 11. Pneumothorax was reduced by half, but because it's a less frequent occurrence, number needed to treat is 20. Hypocapnia reduced by half. That happens all the time, so number needed to treat is only 3. And duration of mechanical ventilation was also shorter. So lots of evidence of benefit, but I want to also point out that while it's really important to control the tidal volume, we need to also make sure that that tidal volume is evenly distributed into a properly, evenly aerated lung, an open lung. What do I mean by that? So we all are used to looking at chest x-rays of babies with RDS, and we think of it as a homogeneous disease, but it's actually not as homogeneous as all that. If you cut the lungs crosswise with a CT scan or MRI, or these days with electrical impedance tomography, you can see that most of the atelectasis is posterior in the dependent portion of the lung, and whatever is aerated tends to be in the non-dependent portion of the lungs. And there is lots of injury happening in all parts of the lung, including the allectatic portion, where there's increased surfactant turnover and inactivation. There's shear stresses at the boundary. There's the process of recruitment, de-recruitment, which is highly injurious. And then maybe there is this nice, healthy little portion of the lung that's staying open during exhalation. The problem here is that whatever volume of gas enters the baby's lungs with whatever mode of ventilation we're using will preferentially enter the already aerated part of the lung. Why? You all remember Laplace's law, right? It tells us that the pressure needed to expand an alveolus or balloon is inversely proportional to the radius. So the critical opening pressure of these allectatic alveoli is much higher than the pressure needed to force gas into the already aerated alveoli. And therefore, the bulk of each tidal volume will enter this healthy portion of the lung and rapidly injure it. And that's not just theoretical, there actually are data, animal data to support that. This is, again, not a new concept. Here they looked at histologic score, hyaline membrane. Okay, so they looked at two kinds of ventilation. Lavage animals ventilated with gentle approach, and here with injurious large tidal volume approach. And it was the non-dependent portion of the lung with the injurious ventilation that took the brunt of the damage, lots of hyaline membranes. Looking at the composite lung injury score, same picture. It was the non-dependent portion, the anterior, well-aerated initially portion that took the brunt of the injury. And similar, looking at various biomarkers of lung injury, again, the same pattern. It was the non-dependent portion of the lung. So this is real, and it's important, therefore, that we don't sit on lungs that are mostly allectatic, that we do something to get them aerated. To do that, you need to overcome your pepophobia and increase the distending pressure. You don't want to continue to ventilate on this inspiratory limb here with poor compliance and lots of diffuse atelectasis, because what you're ventilating is just that anterior portion, which will be rapidly injured. So as you move horizontally here, time-wise, you move up here by increasing the distending pressure. But this will transiently at least lead to overexpansion. Not all portions of the lung are equally distensible, have the same compliance, right? We know the anterior portion will be overexpanded transiently. And we used to not understand that once the lung is expanded, it becomes more compliant. So now you need less pressure to maintain that inflation. So you want to move down on the pressure. You're sliding down the expiratory limb of the pressure volume relationship, and you're trying to find the spot just above the critical closing pressure where lungs will start to collapse again. So that's the idea of optimizing lung inflation. And once you have been able to do that, you're distributing the tidal volume evenly throughout the open lung and minimizing lung injury. And you can these days see this very nicely with electrical impedance tomography. And you hope to be able to get to this state of nirvana where you have pretty nice aeration throughout the lung. So we talk about PEEP. We talked about that issue came up yesterday, I think. So I think I kind of answered this issue. PEEP needs to be titrated to optimize lung volume. It's a dynamic process. There's no one number that works for all babies. Babies who are in room air have well expanded lungs, no ventilation perfusion mismatch. They should not be PEEP of more than 4, at the most 5 centimeters of water. So more is not always better. Too much PEEP is bad, but too little is perhaps even worse. So we need to understand that. We also need to understand that older babies with BPD, severe BPD, need much higher levels of PEEP. So very briefly, some of the clinical guidelines. So compliance changes most rapidly soon after birth, and therefore it makes sense to start early on. We need to pick the right tidal volume. That's a key decision. Finding the right tidal volume is the most important thing. For most typical preemies, between 700 grams and 2 kilo, somewhere between 4 and 5 ml per kilo of tidal volume is the right tidal volume for most of them during the acute phase of RDS, the first days of life. But babies who are really, really small, babies who have meconium aspiration syndrome or BPD, different pathophysiology, the latter two conditions have increased alveolar dead space or wasted ventilation. They need a bigger tidal volume. And I'm going to, so we want to very briefly it works with any mode of, so I'm talking VG here, and similar things apply to PRVC, pretty much the same story. We find it worked better with assist control than SIMV, because with SIMV only the SIMV with pressure support, only the SIMV breaths are being regulated. And of course, you want to keep your pressure limit. You have to set a pressure limit up to which the machine can go, and you want to keep that relatively close to the actual measured peak inflation pressure, so that if compliance changes, you get a signal back telling you that something has changed. So we like to keep it maybe 25% above. And of course, when you look at what's going on, pressure limit is one thing, but the actual measured or PIP or working pressure is what really is the baby receiving. And then of course, babies will come down on their own. So just very briefly, are we completely out of time? How are we doing? Not great. I'll be done very shortly. I know we started late. We keep building a deficit. So this is just very briefly to explain the, and this got a little bit, the formatting got a little bit messed up, but so we looked at a bunch of very small babies to deal with the fact that at the very lower end, the tidal volume seemed a little bit different. And so when we had a normal PCO2, we looked at what tidal volume was being generated. And in the extremely low birth weight infants, around 800 grams. So these were all babies less than 800 grams. The tidal volume was, as we previously and others previously shown, about 4.5, maybe 5 ml per kilo. When you go down to the lower end, what I call the ridiculously low birth weight infants, they needed a bigger tidal volume. And this has to do with the dead space of the flow sensor. So if you're using the servo with a PRVC without measuring the tidal volume, without having the flow sensor proximally, this would not apply. But with VG, where we think it's important to measure tidal volume at the airway opening, the dead space of the flow sensor becomes more significant the smaller the baby. So the dead space of 0.8 ml is a certain percentage of the tidal volume at 800 grams. It's a twice as large proportion of the tidal volume at 400 grams. But because there's some admixture of fresh gas and dead space gas, the tidal volume needed is only a little bit bigger, but it is bigger. Similar data looking at meconium aspiration babies, 40 babies in the control group, which were basically large babies ventilated for various other reasons, with homogeneous lung disease, and meconium aspiration babies. And what you see here is that their tidal volume was substantially bigger. Their minute ventilation was way higher because they were also more tachypnic. So the minute ventilation was 42% higher, but the CO2 was identical. So this tells you that it was all about wasted ventilation. Alveolar minute ventilation obviously was the same. So a different disease requires different tidal volumes. This is the most common problem, is people not paying attention to the fact that different diseases, different circumstances call for different tidal volumes. And if you don't set the right tidal volume, you're going to conclude that the volume targeted ventilation doesn't work. It's not it that's not working, it's us that are not working. So we also looked at those 800 gram baby, less than 800 gram babies over time, a number of years ago. And what we saw as they got older, same thing, collecting tidal volume when CO2 was in the target range. They started in a nice 5 ml per kilo, PCO2 in the mid 40s, perfect. We allowed the CO2 to rise, as everybody does, mild permissive hypercapnia. Despite that, the tidal volume requirement went up to 6 ml per kilo, is a larger standard deviation, meaning a more heterogeneous group. And so this again reflects the evolving pathophysiology of chronic lung disease and increased dead space, alveolar dead space, probably also anatomical dead space with stretching of the trachea. And finally, diaphragmatic hernia babies. What should be the tidal volume be? Well, they only have one good lung. Actually, they don't have any good lung, but so people say, well, ventilating was 3 per kilo. Well, 3 per kilo is dead space. We tried it. Babies pushed back, said, nah, that's not right. That's not working for us. So what we saw was that it was before or after surgery. We needed a tidal volume. We were a little bit more ambitious in those days. This was the data were collected before 2010. It just took a few years to get my fellow to finish the work. So minute ventilation was about the same. Everything was about the same. PCO2, we would probably be a little bit less ambitious today and let the CO2 be a little bit higher. So probably 4.5, maybe 4 ml per kilo is appropriate, but you can't just ventilate dead space. It doesn't work because actually diaphragmatic hernia babies have a higher dead space to total volume ratio. They have normal upper airway, same dead space of the upper airway, but they have smaller lung volume. So the dead space to total volume ratio is higher. If you ventilate them at 3 ml per kilo, it's not going to work very well. And so this is my other plea. We talked about that in the workshop, was that we pick the right total volumes and the right settings. Then we need to ask the baby whether or not he or she approves of those settings. We need to look at their clinical response, look at the graphics, look at whether the baby's comfortable or not, whether the baby's struggling to breathe, still tachypneic, still retracting. And only then we get a blood gas after we've done some fine tuning, because that's what we need to do. Because baby and machine work together, right? And so we need to keep in mind that there is a positive pressure generated by the machine, but added to that is the negative inspiratory effort of the baby. We don't paralyze or heavily sedate our patients. So it's this transpulmonary pressure, which is the combination of the two, that generates the total volume. And with volume targeted ventilation, as the baby generates more and more of the effort, the baby generates more effort, the ventilator component comes down automatically in order to maintain that same total volume. And so we have to understand that if we give the baby a total volume that's below what he or she needs, because maybe there is some metabolic acidosis and baby's trying to compensate, because contrary to popular opinion, it's not PCO2 that's the primary driver of respiratory control, it is the pH. So if the baby has a base deficit, maybe perinatal asphyxia, maybe just immature kidneys and losing bicarb, the babies will try to compensate. And if we give them a total volume that's less than what they need, and they can breathe at larger total volumes, the ventilator will do what it's designed to do, keep dropping the pressure until you, like this, in which case you have a decision to make. If the baby's comfortable and does not have a rising oxygen requirement and is not retracting, for heaven's sakes, extubate them. If the baby, however, is retracting, has a rising oxygen requirement, is struggling, then we need to give them more help. So babies communicate with us if we know how to listen. We just need to pay attention to what they're trying to do. Some ventilators have better leak compensation than others. This is just an illustration of the fact that tidal volume measurement becomes increasingly inaccurate as leak goes up from 0 to up to 80%. There is a feature on the Draeger ventilator that effectively compensates and will maintain that tidal volume calculation very close to reality, the set 4 ml, up until almost 80%. So if you want to read more about it, I wrote a review article a few years ago that talks about a lot of these issues. The one size doesn't fit all. And I'll skip this. Just one word about weaning, which has to do with the fact that volume targeted ventilation will lower pressures automatically as long as the tidal volume is set appropriately. Obviously, if it's too high and the baby's alkalotic, they're not going to breathe. They're going to ride the ventilator. But if the tidal volume is too low, the work of breathing will become excessive and actually can lead to collapse of the lungs, and that's probably not what we want to achieve. And then essentially, once you're down on fairly low settings and baby's comfortable and doesn't have a high oxygen requirement, we can probably extubate. And here we go again, more failure of fundraising. And if you really want to read more about respiratory support, this is the what was previously known as Goldsmith and Karotkin. And this is a lot of stuff about everything we talked about and then some. So it's been a pleasure. Thank you so very much for your attention.
Thank you so much, Dr. KESZLER. I invite to the audience, if we have questions, if you can pass me the paper with the questions. but here we have one of the first questions, and really we have a lot of questions. So we need to try to take advantage of the time. But for example, if no invasive pressure support doesn't work, how can we explain the Ramantan studies report supporting that NIPPV is better than CPAP for extubation?
I didn't say NIPI doesn't work. It doesn't work the way people think it works. It's a stealth way of increasing mean airway pressure. So in his studies, the mean airway pressure with NIPI was substantially higher than in the CPAP group, and that's why it was more successful. So if you want to use NIPI, you can. If you want to blow more gas into the baby's stomach, sure, go for it. But but there is no real advantage to it.
There is here another question. Except NAVA, how do you synchronize NIPPV?
Great question. So in Europe and many other parts of the world, they can use the Grace-P capsule, which is a surface sensor that allows synchronization. There's an Italian company that manufactures a device where apparently they do seem to be able to do flow synchronization with an open system. And I saw it at a conference. It seems to work. So there are some devices in the US. We are protected by the Food and Drug Administration from being able to use excellent, safe devices on our patients. So we don't have synchrony, but it is possible to synchronize. You just have to have the right equipment.
What is the highest PEEP you recommend in ELBW with and without BPD?
So that's a great question. And again, it's sometimes a matter of, it's a matter of titrating it, but there are some studies now actually going on at McMaster in Canada, looking at the same concept that we were promoting, which is instead of NIPV, increase the mean airway, the CPAP, and they're using CPAP of up to 9 centimeters. The Australians will go up to 10 or 12 in their RDS babies. I usually don't go above 9 in the acute phase, but again, it also depends on your interface. So short binasal prongs transmit the pressure fully. So 9, it really is 9 with the RAM cannula. If you set it at 10, the baby's probably only seeing 7 or 8. So it depends on what interface you're using. But there are some studies showing there is really no hemodynamic impairment if the CPAP level is appropriate. So there were animal studies, showing that, when you increase CPAP or PEEP from 5 to 8 to 10, there's progressive hemodynamic impairment. But those were animals with healthy lungs. So clearly 10 centimeters of CPAP would be totally inappropriate with normal lung compliance. But if the lungs are stiff, then you can go higher. So probably most places 8 to 10 would be kind of the limit, but the Aussies are more brave and the Canadians are as well. There is a worldwide variation. I didn't put in that slide, but there's a gradient across the world as to how much CPAP people use.
For infants with severe CLD, what is the recommended tidal volume? 6, 7, 8?
Oh, so babies with severe established chronic lung disease, again, no, it's not one size fits all. It is, some babies need as much as 10 or 12 centimeters. I mean, 10 to 12 ml per kilo, which is a lot, but they have huge dead space, and that's why they need a bigger tidal volume. So.
Yeah, thank you very much, Martin. You did a great talk. And I think one of the things that, in my opinion, you taught us is that we need to learn the language those kids talk to us. So like they speak here papiamento, I don't understand, then I will be in trouble. If I don't understand what the baby's telling me what to do, then I will be in trouble. And the second thing that in my view you taught us is that we have to be simple in the way we approach the baby, and the simpler things to do the better. And we're here to support the baby and not to do every work that baby is doing. And Dr. Lucky, I think your lecture was fantastic. Okay, we really know what you were saying. We have it in our hearts, and we knew fractionally how those things were. But you basically built the puzzle together in such a wonderful way that you don't only touch our intellect, but I believe that we touch our heart more so. And I think I am really translating what the group here is feeling as well as the people in the Zoom. But the other issue here is there is a way for us to cope individually. But I think as we work in a team, in a group, what is your approach in your department to try to make the people to have dealing with these issues?
Right. Carlos, it's really important to create awareness. I think it starts with becoming aware that we are dealing with a crisis in our profession and in our lifetime, and that proactive management requires us to address those issues. Our previous history is we brush them under the carpet. You know, we say our floor is clean, but the dirt is still accumulating under the carpet. So it's really important that we address issues as they are. And I at my own institution, we've secured a lot of funding to be able to do this. We have a lot of wellness programs. We have a peer supporter program that I'm particularly proud of, in which if there is a death in the hospital, in the ICU, or anywhere in the hospital, within a few hours, a peer supporter will be reaching out to the team to make sure that everyone is doing okay. And then there is follow-up action to make sure that the nurses, the respiratory therapists, the doctors taking care of the patient feel supported. Yeah, so little things that we can do. We have started a 24/7 support line for emotional and mental health. Anyone from our healthcare system can call that support line and seek help. So little things over time, Carlos, that are beginning to make an impact. If I could go back to Marty, your talk, it seems to me over the years that we continue to always be itchy to bring in new toys and new what do you call them? New drill powered screwdrivers, and when we bring them home to do projects, we do more harm to the project that we are trying to achieve than help. And so I think what Dr. KESZLER has been trying to teach us is that if you in your unit decide that volume targeted ventilation and CPAP are two time-tested, good modalities to ventilate patients, and we train ourselves to do it perfectly, there is no reason to keep on constantly changing. I mean, help us understand, why is it that we're also always so fidgety in trying to, to change, when really the beauty is that if we know how to drive our car the best we can, we just don't stray from the path.
You're absolutely right. It's better to do one thing well than 10 things poorly. But it has to do, I think, with our personality. We're a self-selected bunch of adrenaline junkies who always want to do something fun and exciting. So, but your point's very well taken. We should learn to use 2 or 3 tools really effectively and have a standardized approach that allows for patient individualization for each patient, but has an organized approach. So you're correct. And very often less is more. And we should not escalate needlessly. Babies can manage despite our dire predictions sometimes quite well. So, but, I see from the questions that people are, wanting to look at more weird things like mandatory minute ventilation. Well, there's not a lot of evidence for it. I mean, it's another toy. It only is helpful when you're using SIMV. It's not widely used. I'm looking at one of the questions. I know we're kind of short of time.
Yes,
to
we are
guide us.
short of time. We will do 2 more questions and we will go to a very short coffee break after, and we will return really fast because we are starting to have pressure, all the people from here. Okay. Not from here, from the hotel, not our team. Okay, the question, do you make some recruitment maneuvers like critical open pressure and close pressure before you initiate volume guarantee ventilation, or don't?
So in practice, it's too complicated to try to and difficult in an actively breathing baby to define the critical opening and closing pressures. So essentially, you do it by increasing. If you have a high oxygen requirement, that means you need to do something to open the lungs. So you do a stepwise increase. So as oscillatory ventilation, you increase the mean airway pressure. With conventional ventilation, you stepwise increase the PEEP, the end expiratory pressure, until oxygenation improves, and you can wean to less than 30%, or until there's no further improvement in oxygenation with 2 stepwise increases. And then once the lung opens, you want to come back down on your mean airway pressure until you're beginning to see deterioration in oxygenation. That's the basic principle. In real life, usually you just, with effective surfactant, you don't need all that much recruitment, but you don't want to sit on an oxygen requirement of 50%, which is due to lung disease. You want to try to recruit the lung with that. Somebody's asking about recommended IT with severe BPD. That's a quick question. Look at your flow graphics and make sure that the inspiratory time is long enough to deliver your tidal volume. Usually it's going to be at least 0.5, sometimes as much as 0.7 seconds. But the graphics will tell you for this particular baby what the inspiratory time should be. Non-invasive HFO, we don't do it. Yeah, I think it's experimental. Some places in Canada do it. I think it depends on the interface. If you have large enough short binasal prongs, it probably works, but it can easily also be dampened. So I think the jury is out on that. Quickly answer the couple.
Sorry, can we, because you spoke about RAM cannulas. We didn't understand, because I think it's the one that we all use, the RAM, the little prongs and the long little.
Yeah.
Yeah. Which are the others? I mean, which other do you need to?
So
what is the possibility?
there are a variety of short binasal prongs that.
But these are, I mean, very tiny ones. I don't.
Yeah, I mean, well, they come in different sizes. So Fisher-Paykel makes them. Lots of manufacturers make these short binasal prongs. The RAM cannula with that long tubing does not transmit pressure very well, and there is
because you mean the long the size between here and the
yeah.
connection.
So the connection is back there, right?
Yeah,
There is
that's the ones I think everybody
Is
uses.
this what people
Yeah,
use?
Latin American.
Oh.
Yes, the long. Yeah. Not here. Here? Yes.
High flow. So it's a high flow cannula. It's not really CPAP.
Right. It's
Because-
the uh-huh.
So if you're using it for high flow,
That's
it's
okay.
fine.
Oh, okay.
It's
All right.
fine as a high flow cannula.
Oh,
It's
okay.
not fine for CPAP.
Oh, okay. Okay. I'm sorry. Thank
If
you.
Okay, thank you so much, Dr. KESZLER. Sorry for the persons that we couldn't respond the questions, but I invite you really fast to a coffee break of 5 minutes, and after we will return for our last conference and the closure of our conference. Thank you so much.